Okay, thank you everyone for joining. This month we're going to be doing with Rover transoral robotic surgery. We have a wonderful panelists with radiation oncology, medical oncology, and ENT. And with that, some ground rules. If you have any questions, put it in the chat and remember to put it to everyone. You can also use the Q&A and we'll try to get to all of the questions as we go through. There's nothing else. I'm going to hand it over to Anne and Teresa.
Thank you all for joining today.
Hi, thank you for.
Before we get started, we'd like to give just a moment for our panelists to introduce themselves. If we could start with Dr. Beadle.
My name is Beth Beadle. I'm a head and neck radiation oncologist at Stanford.
Great. And Dr. Lukens?
Hi, my name is Nick Lukens. I'm a head and neck radiation oncologist at University of Pennsylvania.
Great. And Dr. Michelle Chen?
I'm Michelle, and I'm a head and neck surgical oncologist, just transitioned from Cedars to Stanford.
And Dr. Siddharth Sheth?
Hey everyone, I'm a head and neck medical oncologist at UNC Chapel Hill.
Great. We're so excited to have such a great panel, truly representing the multidimensional care that all of our patients with head and neck cancer receive. If we go to the next slide. This is Teresa and I'm in my first year attending job at Mayo Clinic. And Teresa, if you'd like to introduce yourself.
Hi, I'm a PGY4 resident at University of Minnesota.
Great. And with that, we'll dive into the cases.
All right, first up is Dr. Beadle.
All right, if we can go to the next slide. This is a 79-year-old male who has bilateral hearing aids who presented with irritation in the left tonsillar area. He decided to deal with this himself, so he lanced the area with a sewing needle with expression of blood and pus, which I anticipate makes all of us nervous. And then over the next 3 months, he just saw his local primary care physician who was concerned about tonsil infection, and he was given antibiotics, but the lesion persisted. He then went to an ENT physician, a general ENT physician, who noted a left tonsil mass, which you can see in the image here, and no palpable adenopathy. So I don't know, Dr. Chen, if you want to get us started. So I know you're a your specialty is head and neck surgeries, but if you can put your general ENT hat on from long ago, what do you think general ENTs are looking for situations like this? What is the concern, and what would be the next evaluation step?
Yeah, great. I think every general ENT candidate will want to, when we have asymmetric tonsils and left tonsil mass, we're always worried about making sure to rule out cancer. And then they're probably always thinking like infection, peritonsillar abscess. Given his age, I think the main thing is to do a biopsy to rule out a neoplasm and then send him to a surgical oncologist if that is indeed the case.
So how do you do this biopsy? Would you do imaging beforehand? Would you take it in the office? What makes the decision to do a biopsy when he's sitting in front of you versus taking him to the operating room or waiting to see other information?
Right, good question. So if I see sort of an exophytic mass that's, I can get to transorally in the office, and I make sure I don't feel any carotid pulse or anything that would cause a undue harm in taking a biopsy. I often just do the biopsy before imaging. That sort of expedites the process of getting a diagnosis. And, I think most general ENTs will probably just do the biopsy and then sort of maybe get a CT neck and then send to sort of a specialist. If, there was any concern that was more like a vascular mass or it had sort of deeper extension and was very endophytic, and I felt like I couldn't get to it without a sort of operative direct laryngoscopy, I would take him to the OR. But for something like this, which you can see transorally, an office biopsy would be perfectly fine.
Okay, next slide. Okay, so for the rest of the group, who would move forward with biopsying the tonsil? Who would do imaging? Who would do surgical resection or radiation or chemotherapy right now? Okay. Okay, so Dr. Chen was fairly convincing that most people are, that there's definitely some comfort in doing the biopsy, but there's definitely also an interest in doing imaging for the patient before you start. Dr. Lukens, what do you think about that? What do you see in your practice? How many patients in a setting like this would go to imaging versus a biopsy up front?
I guess the more common presentation that we see is patient sees they're shaving, they notice a neck lump, they see their primary care doctor gets a CT neck that shows pathologic lymphadenopathy. They're sent to their ENT surgeon. They have a fine needle aspiration that shows a P16 positive squamous cell carcinoma, and then they go and have DL for the primary site. I think that's a more common thing that I see. So I haven't seen this too often, but I think probably a CT neck would be the next step.
Yeah, I think it's a challenge because you definitely have a target for a biopsy, and I think there's definitely some ENTs who are comfortable doing that, but the yield on tonsil biopsy is not always great in the office. But you also end up running in the risk of, if you order imaging, without a cancer diagnosis, sometimes you can get pushback from insurance companies and things like that for that. Okay, next slide. So in this case, they did move forward with a biopsy that was positive for squamous carcinoma, and then there were images. I don't know, Dr. Sheth, if you want to take a look, what are you concerned about here? What are you thinking for this case in the setting of the clinical scenario as well?
Yeah, absolutely. So here you can see, and I agree, I think this, the more classic presentation is and the one that you'll see on your board exam is a patient who has a painless neck mass while shaving. But yeah, so what we're looking at the radiographic images here, you can see, well, I can't use my pointer, but you can see this left-sided mass here. Here you go. And then so we're also looking for a primary tumor, and then looking for any evidence of cervical adenopathy, which nothing is really showing up that's too obvious here on this scan. So this is going to be important for helping us determine what the next step for staging is and how to triage in terms of which specialist should see this patient.
Okay, all right, if we can go to the next slide. Okay, so we did a biopsy, as Dr. Chen noted, that showed P16 positive squamous carcinoma of the left tonsil. The only lesion seen was that seen clinically, which measured about 3.5 centimeters in size. There was no adenopathy on examination or imaging, so it's a T2N0 left tonsil lesion in a 79-year-old. So who would recommend surgery-based treatment followed by adjuvant therapy, radiation, or chemo as indicated, and who would prefer a radiation-based treatment? While that's moving forward, Dr. Chen, what would your comfort level be in treating a patient who is 79 with a surgical-based approach? And could you tell us a little bit about what that surgery would be just based on the cancer?
Yeah, I think, age is sometimes just a number, so it really depends on their comorbidities, right? I would, if he's otherwise healthy, then depending on the scope exam, I would probably move forward with surgery-based treatment. But if there was, if he needed to be on anticoagulation, if he had was very frail, wheelchair bound, if there are other things I would think about in terms of surgery. You want it in the picture, it looked like it was very visible transorally, and he had good mouth opening, but you always think about sort of mouth opening exposure of the tumor in surgery. And then, what we look on our scope exam is sort of how mobile it is, right? We want to make sure it's not involving the vallecula. That's just sort of in the tonsil going down the GTS, but not into the larynx or the supraglottic structures. And then that is fairly mobile. I get, superiorly, I look at the soft palate and make sure there's not that much soft palate involved. Otherwise, a surgical resection in the 79-year-old can cause a lot of functional deficits. So I think my scope exam and then the patient's comorbidities really guide my decision-making.
Yeah, well, to add in, so he's 79, but he's actually a competitive downhill skier. I know Dr. Palm's teaching herself to ski, and I think that he would probably be a really good yet scary teacher for this. So he was super functional. He did have the hearing aids, but otherwise really performance status was 0 for someone of any age, let alone his age. And to your point about nuances of the physical exam, really it was tucked into the tonsillar fossa. So there was a little involvement of the anterior tonsillar pillar, but it didn't involve the soft palate and it didn't involve the base of tongue. It really just folded in there between those structures. So definitely to answer those questions, I think that, he could be a surgical candidate. Dr. Lukens, what about you? I think there's some concern about age and surgery, but there's also some concern about age and radiation. What do you think about option for this patient? Which direction do you think you'd lean?
So I see a lot of these patients before surgery at Penn, and we often have a discussion in terms of the potential benefits of surgery here. I think mainly being the potential to avoid adjuvant therapy if it's a resected tumor with no pathologic risk features and node negative. I think you could potentially just observe the patient post-op. Or the other argument that's made is, I think you could probably treat this patient with radiation alone, but if you're thinking about concurrent chemoradiation, potentially using surgery to avoid concurrent chemotherapy, if you think there's a low likelihood of ECE, with the caveat that we're pretty bad at trying to predict ECE based on preoperative imaging. I don't think age in and of itself is a contraindication to doing TORS. The TORS surgeons here have done some research showing that the older patients actually do quite well with a TORS-based approach. I don't think age in and of itself is really too much of a consideration here. So
Okay.
I think I would have a balanced discussion. I usually say the patient is going to do well either way. I think it's just about the functional outcome.
Great. Okay, and it looks like there was some favoring of radiation-based approach in the poll. Next slide. So Dr. Chen was extremely convincing, or one of her partners. And so the patient did go for a transoral robotic surgery of the tonsil mass and a left neck dissection. So you can see there was a 3.8 centimeter HPV positive squamous carcinoma and the margins were negative. Additional margins were sent and were also negative. And they did a neck dissection, and that you can see, despite the fact that he was clinically and radiographically N0, surprisingly, he had 3 of 5 lymph nodes in level 2A that were positive. The largest deposit was 7.5 millimeters, and there was extranodal extension present. How common do you see this, Dr. Sheth? How often do you think you're surprised in a clinically node negative neck to have this type of finding?
Yeah, at least from my experience, and I think there's clinical equipoise about whether to do surgery or radiation therapy, and it's really patient preference and some of the other factors, and also institutional preference. But in terms of seeing a pathology report like this, I find this to be a little bit surprising from our experience, and wouldn't necessarily expect not only to see nodal involvement, but also ECE that wasn't there.
Dr. Lukens?
I agree. This kind of presentation always makes me wonder if this is an HPV 16 subtype or one of the other subtypes that generally have a more insidious natural history where you see multiple small nodes with ECE that you wouldn't have detected on pre-op imaging. So I might consider, I know it's controversial, but maybe NavDex testing to see what the HPV subtype, just because I'd be curious, because this isn't the usual presentation.
Would that change your subsequent management?
Good question. Probably not. It is going to be a criteria for some of the adjuvant trials that we have. So it's something that we think about getting nowadays.
Okay. All right. Dr. Chen, what would you tell this patient about his expected recovery from this procedure? How long would he be in the hospital? Would he need a feeding tube? Would he need a breathing tube, pain medication? What do you think the typical recovery for the general population is?
Yeah, so generally, especially for like a tonsillar primary, we don't, and I think most institutions have moved away from putting prophylactic feeding tubes in patients. And in general, unless there's a flap involved, we usually don't trach the patients either. And so we would have them sort of work with our inpatient speech language pathologist and start swallowing, post-op day 1. Usually we have a pretty good sort of pain, multi-modality pain regimen for these patients, including like gabapentin, opioids, and Celebrex, and steroids. And then, they usually stay in the hospital mainly to watch for pain control, as well as oral intake for anywhere from 2 to 5 days. And in general, I tell them, no travel outside of the immediate area for the next couple of weeks, because that's when the highest bleeding risk occurs. And, it doesn't say here, but, in general, most of us ligate the branches of the external carotid during surgery to try to minimize the bleeding risk. And that's sort of the main complication we counsel on extensively from a surgical standpoint.
Okay, can we go to the next slide? So the patient unexpectedly now has node positive cancer with extracapsular extension. So what would the recommendations for these patients be? So for him, observation, adjuvant radiation alone to the primary and the ipsilateral neck, adjuvant radiation alone to the primary and the bilateral neck, adjuvant chemoradiation to primary and ipsilateral, or adjuvant chemoradiation to primary and bilateral. Dr. Lukens, how would you have treated this case intact? Would you have treated this case unilaterally or bilaterally?
Interestingly, would have treated unilateral neck because the primary was well lateralized and clinically node negative.
How does this pathology change that? Would you still treat in the postoperative? If you are going to treat, would you treat unilaterally in the postoperative setting, or would you add bilateral neck treatment?
I'm always on the fence here because I look at both the primary site features, which we already talked about. This was well lateralized, as well as the extensive pathologic lymphadenopathy. And here with 3 nodes positive, with ECE, starting to think about treating the contralateral neck just because I think there's a higher burden of cells within the lymphatics, but I think there's more and more data coming out over the past several years showing that you can probably get away with just treating the ipsilateral neck here.
Okay. I can see the poll came in that there's 50% said adjuvant chemoradiation to the primary and bilateral neck, and then it was split 25% each with chemoradiation to primary and ipsilateral and radiation alone. Dr. Sheth, I'll remind you the patient is 79 and has hearing aids. So can you tell me about what you would do in general for a patient with this pathology, and then if those issues affect your recommendation for this patient?
Yeah, absolutely. I think there are 2 factors that we see in this surgical pathology that matter. So one is extracapsular extension, which is considered a high-risk feature, and then perineural invasion, which we can consider intermediate risk for disease recurrence. So based on some older data, but I think patient with ECE would qualify for adjuvant radiation or chemotherapy concurrently with radiation therapy. So that's what would be recommended for a general patient. And for this patient, the fact that he has some hearing issues would not disqualify him for concurrent chemotherapy. We would just have a discussion about potentially using alternate agents other than cisplatin, which is a standard of care. And there are multiple decent options that are non-cisplatin based that we could consider.
Dr. Lukens, your thoughts?
Yeah, I think it's worth a balanced discussion, and certainly a referral medical oncology. I think most of the medical oncologists at Penn would probably err on the side of giving this patient concurrent chemotherapy, and the regimen that I often see is concurrent carbotaxol. And I guess I would be curious to hear your experience, Dr. Beadle. I find that to be a pretty potent radiosensitizer. So although it may be better tolerated as far as some of the other things we think about with age and hearing loss and so on, I find that it does, these patients tend to have more mucosal toxicity. And so I sometimes get a little nervous with, concurrent carbotaxol for these patients.
I agree. I think this is an interesting case, and it's the reason I picked it, which is we're going from a patient that had we not treated with surgery would have probably treated with unilateral radiation alone. And now we've rung a bell that we cannot unring, that show and have gotten data that we would not know we have, which now potentially, if you follow official guidelines, would probably mean that he would get radiation. Unilateral versus bilateral, I think, is controversial and would qualify for chemotherapy, which would be typically cisplatin. In the absence of cisplatin, if he does have profound hearing loss or another contraindication like renal dysfunction, I don't think we've got a great proven, we have a lot of good options, but we don't have great data on a secondary post-operative a concurrent agent. So I agree. I think carbotaxol can be very effective, but also it does have its own toxicity, especially mucosally. So I don't think we've got a great option on this. And it just shows that, again, more data sometimes gets you into a place that, I think we could have probably had quoted this man a cure rate of over 95% with radiation alone, unilateral upfront, but now we're trying to figure out how we can integrate these these pathologic factors that we wouldn't know that we had. Next. So just to sum up my part, so we did elect to treat him adjuvantly with radiation and to 60 gray and 30 fractions to the primary site and ipsilateral neck, with the argument that, again, the largest deposit in the neck lymph nodes was 7 millimeters. And so we didn't think that this necessarily would affect lymphatic drainage. And based on what Dr. Luken said about laterality of this tumor, we felt comfortable doing this. We had a long conversation about him, about the potential for adjuvant chemo radiation. There was concern because of his hearing loss and his functional status about adding cisplatin. So we elected to go with radiation alone, which again, sort of ignores the extranodal extension, which I'm not sure we should do. There is actually an ongoing trial run out of the UK called the Pathos trial, where patients are taken for TORS and nodal dissection. And if they're intermediate risk, they're randomized between 50 gray and 60 gray of radiation alone. And if they're high risk, positive margins or extranodal extension, they're actually randomized between chemoradiation versus radiation alone. So hopefully we'll get some answers in this HPV P16 positive setting about whether or not there's an additional benefit in situations like this, where we didn't expect to see these outcomes, but we found them in the end. I think that finishes my case. Thank you all.
Beth, could I ask you a quick question about this case? What
Sure.
was the degree of ECE in this case? Was it less than 1
It was
millimeter?
less than 2. It was less than 2 millimeters is what they said.
Interesting. So
Yeah.
have you been, the reason I ask is for some patients who would have qualified for the ECOG 3311 trial, we get into this, discussion of could you have just treated this patient with radiation alone to 50 gray if they had microscopic ECE. So we sort of pushed the pathologist to try to quantify the degree of ECE, and be curious, Dr. Chen, is that something that you do at your institution, where you try to quantify the ECE to treat patients per the ECOG trial?
Yeah, actually at Cedars, we actually have pushed the pathologist as well. So now they quantify it by the millimeter. And if it's less than 1, we don't give chemotherapy, at least our medical oncologists.
Mhm. What about you, Beth? Is that something that you guys have moved towards?
Yeah, I think in situations like this, we do ask them to quantify it so that we can get some idea of where they go. Would you have treated this patient in the absence of that? Have you integrated ECOG 3311 into your practice? So in the absence of the ECE, would you have treated this patient to 50 or 60?
Great question, loaded question. Starting to get more comfort with 50 gray for these patients. We have our own trial treating to 50, and this patient would have probably not gotten chemotherapy had the EC been less than 1 millimeter. So I do have a little bit more comfort now with that, but I would say take it on a case-by-case basis, obviously.
Great, and with that, we'll move on to our next case. Thank you all so much for the discussion and for leading us, Dr. Beal.
I think we had a question in the chat.
I saw, it looks like Dr. Beadle's typing her answer for it, which was about the
Oh,
time
perfect.
interval. Oh, yep, looks like, there you go, now it's in the answered section. Awesome.
Awesome. Okay, we'll move on. Our next
I
case.
think we talked through those so we can go on to Dr. Lukin's
Yeah.
case.
Thank you. All right. Next, Dr. Lukens.
All right, so you can go to the next slide. So this is an 81-year-old male who presents with dysphagia, right ear pressure, a sore throat, and hoarseness. He has a CT neck, shows a 1.8 centimeter right tonsillar mass and a single metastatic right level 2B lymph node measuring 1.6 by 2.1 centimeters. He is referred to an ENT. Next slide. This is the CT neck that's obtained. You can see there's a, see if my mouse works. Yes, thank you for driving. There's a mass there within the right tonsillar fossa and a single ipsilateral level 2A node that you can see there. Yep, perfect. So the next step here, we sent you an ENT. I think if you go to the next slide, there may be a quiz. Oh, no, there's no quiz. So patient goes to the ENT, has a DL with biopsy, and of note in the operative note, they see a right palatine tonsil mass, and it's noted that the lesion is high on the soft palate and is anticipated to result in a pharyngeal defect requiring soft tissue reconstruction. The biopsy shows a P16 positive squamous cell carcinoma. So I would throw this to Dr. Chen at this point. What are your thoughts in terms of surgical candidacy?
Yeah, I think for this case it's a little bit more nebulous. I think for me, when there's sort of some high soft palate involvement, I am a little bit more gun shy. I often have a much more frank conversation with the patient. You know, you have another good, as long as he's like a good candidate for chemo and radiation, given his comorbidities. I do think with soft palate involvement, they're a high risk for velopharyngeal insufficiency, rhinolalia, and their speech and swallowing function may suffer after surgery. If you place a free flap in this area for soft tissue reconstruction, it tends to be an insensate piece of tissue, and often we can't sort of recreate the functional nature of the soft palate as well as what's innate. And so I would be a little bit more hesitant about surgery in this patient, but would have a frank conversation with the patient with radiation oncology and medical oncology.
Great, thanks so much. That's really, let's go to the next slide. Next slide. You can go forward one. So the case was discussed at multi-D tumor board, and it was noted by the neuroradiologist that there was a pathologic right retropharyngeal lymph node right there. So if you go to the next slide. Well, question one, I think there might be a little bit of a delay here. So what is the risk of, how about, let's reword this, which subsite within the oropharynx has the highest risk of RP nodal involvement? on, see what people think. Don't really expect people to know this, but I think it's interesting if you go on posterior. Yeah, you would think that is obviously very high risk along the posterior wall. There's one study in particular with a small n. If you go forward, yeah, that's perfect. And if you go forward once more, it'll give the reference as well. In this one particular study, which is one of several, this suggested that actually patients with soft palate involvement have a particularly high risk of RP nodal involvement. In this study, it was up to 50%. Certainly, the posterior wall of the pharynx and the tonsil are also relatively high risk. Let's go to the next slide. So here, we have a patient who has a, all right, let's go to the poll question. What's your recommendation at this point? Maybe to summarize, it's a clinical T2N1 P16 positive squamous cell carcinoma of the right tonsil with an RP node that's positive. So would you recommend surgery followed by tailored adjuvant therapy, radiation alone, chemorads, or induction chemotherapy, then radiation? Right. Well, good. I think that's interesting. This is, of course, a TORS panel, so I think you know the treatment that this patient had. I guess, would be curious to hear, Dr. Chen, if you know in advance that there's going to be a positive retropharyngeal lymph node, does that affect what you recommend in terms of surgery, yes, no?
Yeah, I think I would actually probably favor chemoradiation because I think there's a couple things. You can access the retropharyngeal node surgically, and in this case, you've already, with the soft panel, you're already committed to a free flap anyway. So in some sense, you're covered there, but there are some RP nodes that are much more difficult to access, and I think in general, having an RP node portends sort of a worse prognosis in terms of overall survival, increased risk of distant mets. And given his age, and I already thought surgery was sort of borderline for him, I would probably favor chemoradiation.
Okay, that's very helpful to know. What's your, as a surgeon, are you able to get around these RP nodes, so to speak, or do you more or less expect that there's going to be a very close, or if not a positive margin in the RP nodal space?
Depends how high it is. I think if it's getting close to the nasal pharynx, it's pretty hard to get to, but because you have basically the posterior pharyngeal wall area exposed with TORS and the neck exposed, you can pretty much trace up the carotids and get the RP nodes, and then you've already prepared for a flap, in this case, to cover the carotids. I just think the functional deficits from all of this would be quite morbid for this patient.
Sure. Okay, thanks. All right, we can go to the next slide. Next slide, please. Sorry, this is a little, okay, so he had surgery consisting of TORS, right neck dissection, and he has a flap placed. We can go to the pathology on the next slide. I have to advance once more, sorry. There we go. So this showed a 2 centimeter HPV associated tumor. There was extensive lymphovascular invasion, a 2 millimeter deep margin. From the right neck, that lymph node, that RP node was positive, there was ECE. And then from the right neck levels 1 through 4, there were 4 lymph nodes positive with ECE less than 1 millimeter. So the patient was referred to radiation oncology because of problems with wound healing with this flap post-op. We saw him about 6 weeks post-operatively. Let's go to the next slide. So what's your recommendation? Well, I think we recommend adjuvant radiation with concurrent chemotherapy, and this kind of plays into the conversation we had before. This patient wears hearing aids, so cisplatin was not recommended. And then I guess the question I wanted to throw out there, and sorry I don't have a poll question for this, is this patient an appropriate candidate for de-intensification? So his pathologic end stage, he's pathologic N2 because he has 5 positive nodes with ECE. So Dr. Beadle, would you recommend, what are your thoughts on a de-intensification for this patient?
I would try to intensify things for him. I think everything suggests that this is aggressive. I mean, the primary is probably the least of his problems, although it was in an inopportune location, but the multiple positive lymph nodes and that retropharyngeal lymph node are all going to be extremely hard to salvage if we don't get these right. And the extranodal extinction also makes this higher risk. So even using traditional definitions, he would be considered high risk. And I think on all of the trials would be shunted to a chemoradiation arm. So I think it's a challenge now that he's had the wound healing issues and things like that to figure out how to appropriately move him forward, because already we've had a delay. It looks like we'll have a delay in starting his adjuvant therapy.
Mm-hmm. Yeah, I think that's a good point. We do have some data that's coming out, in particular from the DART trial for high-risk patients. The pathologic N2 patients with ECE had relapse-free survival that was less than 50%. So a little bit of a cautionary tale about trying to de-intensify for these patients. Now, some of that reflects a higher risk of distant metastatic disease, but certainly this patient is at quite high risk of local regional recurrence. In this case, we got a PET CT at the time of simulation. He had not had a PET for staging before, so we got a PET CT at the time of planning, and you can go to the next slide. I have a low threshold for these patients who have particularly high risk pathology. I usually get a PET to make sure we're not missing any gross disease. In this case, he did have a hypermetabolic right cervical lymph node that was read as being positive by the radiologist. He didn't have any distant metastatic disease. So I guess, at this point, we're sort of committed to concurrent chemoradiation. And if you go to the next slide, these are challenging cases to plan because essentially we try to get 70 gray, right? We want to boost that node to approximately 70 gray. The areas of extensive ECE, we're going to try to boost to 66. 60 gray to the primary resection bed and the right neck, and then we treat this quote-unquote low-risk neck to 56 gray. There's always the question, do you dose paint or do a sequential cone down? I prefer to dose paint because you have much more control over where the dose is going, especially if you've got 4 different dose levels. It's very hard to do a sequential cone down. So in this case, we treated over 33 fractions with an SIB technique. If you go to the next slide, next slide, please. So this shows this small volume is getting 70 gray. That's the positive node. Next slide. This, if you look at the coronal and the sagittal here, you can see those areas that are getting 66 gray, the ECE, those regions with ECE. Next slide. This was the 5940 volume, basically the resection bed and the right neck. And then the next slide shows you the 56 gray, which is the contralateral neck. And I just wanted to point out here that we are treating the contralateral RP nodes up to the base of skull, given that there was RP nodal involvement and pretty extensive soft palate involvement. So what we'll sometimes do in these cases is we'll track the RP nodes up to the base of skull, but not treat the retrostyloid nodes high up in the contralateral neck to try to reduce the dose that's going to the contralateral parotid gland. If you go to the next slide, this shows, so this is the dose distribution on the left, and then on the right, this shows a couple of key OAR doses. So you can see that we're able to keep the parotid constraints well below our goal. We try to keep the contralateral submandibular gland to about 30 gray, and we can usually get away with that. And here with the use of protons, we're able to get the oral cavity mean dose quite low, which we know helps to reduce long-term xerostomia. But I think unfortunately, as good as a job as we can do with radiation here, I think, as Dr. Chen mentioned here, the functional outcome is going to be determined primarily by the extent of resection and the reconstruction of the soft palate. So if you go to the next slide. So I think, the challenges of this case, always consider the risk of RP nodal involvement and how this may affect your management. I personally have a low threshold to always get a PET CT for planning in cases of particularly high risk pathology, and I'm often surprised by what we find. Know when not to de-intensify, when to think about treating the contralateral RP nodes, in particular for E4, tonsillar case, and then how to dose paint. And if you go to the next slide, as far as the functional outcome for these patients, he continues to be NED now about 1 year post chemo-res, but he recently saw speech and they noted continuing dysphagia, and he's eating a soft diet. So this is, I think, relatively common in these patients who have had a flap reconstruction when they have to take a significant portion of the soft palate. What is your threshold, Dr. Chen, for when would you consider placing a flap? I guess, do you ever place flaps? Who do you think are the patients that are most likely to benefit from a flap placement versus not?
Yeah, so I think any salvage case, I almost always do a flap just because you have prior radiated tissue. And so any salvage oral pharynx TORS case, I think having free tissue is helpful. And then, if there's only, 25%, less than 25% of the soft palate, I can usually rotate mucosa over a buccal fat to close it. But more than that, you probably need a free flap to close the area and separate the oral pharynx and cover the carotids.
I guess one other question that often comes up is whether you need to stage the neck dissection and the TORS resection when these patients don't need a flap. So oftentimes, to reduce the risk of bleeding, the surgeons here will do the neck dissection first and then ligate branches of the external carotid and then do the TORS a week later. Is that always necessary in your experience?
I don't think so. I mean, at Cedars, we had very limited OR time, and so we really didn't stage them for practical reasons. But I think, what we do is we do the TORS first, and then while our margins are cooking, we do the neck, we ligate the vessels. Because it's really not, when you ligate the vessels, it's not really for bleeding at the time of TORS necessarily, because that's always controllable. You're in the OR, but it's for post-operative bleeding. And so that's why I think it doesn't really matter to do it simultaneously versus staged. And there are some people that say if you wait too long between the neck and the TORS, you get sort of neovascularization and backflow. And so that also increases your risk of bleeding. And so I haven't really seen a difference with staging it versus not staging.
Okay, great. Thank you. I'm not sure if there's any questions from the audience.
We haven't had any. Nope.
Right.
Well, I was just wondering, so from my perspective, I don't think our group would have been enthusiastic to operate on this patient because of the nodal involvement in the retropharyngeal adenopathy, in addition to the placement of the primary. I was just wondering from another perspective, Dr. Sheth, what do you think would be standard at your practice?
Yeah, I think similar reasons with the RP involvement, our surgeons would not offer surgery, and this would be a concurrent chemoradiation therapy as a primary modality. And I think for the participants too, that while hearing is important and the patient has hearing aids, I think there are, while less superior to cisplatin, there are alternative radiation sensitizing agents that we could offer for them.
And it's been alluded to a couple of times during this panel with carbotaxol being one of those options. Are there other regimens that you like as cisplatin alternatives?
Yeah, so we actually don't use a lot of carbotaxol for head and neck patients. So alternatives here would be cetuximab, which we know in the HPV associated space is inferior based on 2 large phase 3 trials. And there was a nice study that actually showed that single agent carboplatin may be superior to cetuximab, particularly in oropharyngeal squamous cell. So, we typically, as a backup, I think there's 3 options. One, for a patient that wants to be aggressive and is willing to accept the risk, we would consider cisplatin and maybe do 30 milligrams per meter squared weekly. An alternative would be either carboplatin or cetuximab.
And I would like to point out for patients with, I think we have better data in the definitive space. So for patients who have intact tumors, I think we do have better data on cisplatin alternatives. One of the big studies to look at this compared to cetuximab and durvalumab, that's Energy HN004. It was closed early, and the results are going to be presented at ASTRO in 2 weeks at the plenary session. So that compares for patients with multiple comorbidities or that are cisplatin ineligible for a variety of reasons, those 2 things. So we'll have some more data in that space. I think it's a harder sell in the postoperative space. There was a big study 0920 comparing radiation alone and radiation with cetuximab that has yet to be for intermediate risk factors, not for high risk factors, and that has yet to be published. So we don't really know about it in the postoperative space. So we don't have great data for that, but in the definitive space we have more, and there's more coming in 2 weeks.
And there's also a question in the chat for Dr. Sheff on cis weekly versus every 3 weeks in the Q&A. But I think in the interest of time, we might move on to our next case.
Sure. All right, I will present the last case courtesy of Dr. Beadle. So this is a 61-year-old male, never smoker, who presented with throat discomfort. He was sent to ENT with the exam revealing the following. So for our first poll question, what do you see? An exophytic mass of the right base of tongue not involving the area epiglottic fold or the vallecula, a well-lateralized mass arising from the right glossotonsillar sulcus, an exophytic mass along the right posterior pharyngeal wall, or an exophytic mass that arises from the right oropharynx approaching midline involving the epiglottis.
And while we give people just a moment to answer, I had a question for Dr. Chen, which was about some of your different maneuvers for testing mobility of lesions. I'm kind of used to asking people to say ah and e and puffing out their cheeks and sticking out their tongue, but do you have other favorite tricks?
I think those are the main things. I think when they move their tongue, it opens up the space in the vallecula, and I think that's really helpful for these base of tongue masses. And then I think also manual palpation is really helpful in terms of depth and mobility. And I think it's quite gaggy for the patients, as some people are a little bit shy, but it's really helpful in surgical planning to really palpate the mass and get a sense for how mobile it is. And then you can also feel for submucosal extension towards midline.
Great, thank you so much.
Okay, well, kind of some mixed responses here. So answer is, as we kind of already alluded to with Dr. Chen, this is an exophytic mass arising from the right base of tongue that is not involving the area epiglottic fold or the vallecula. Okay. So for a differential diagnosis for a base of tongue mass, we have another poll question.
And I'll say that I think that the answer to this question is kind of asking, which do you think this particular one is? But that's hard in a panel on head and neck cancer.
I think we all know where we're going here. So yeah,
Although I guess a question for Dr. Chen could be, how often is something like this not a squamous cell carcinoma? By the time they make it to our clinics, it's always cancer.
Yeah, I think in the general ENT PCP practice, more often than not, it's not cancer. You can have prominent, like sort of asymmetric base of tongue, and like on CT scan, the tongue base can look asymmetric just for like asymmetric lingual tonsils, and then that can like prompt an ENT workup, and it's just sort of, asymmetric lingual tonsils, or they can just have asymmetric palatine tonsils as well. I think, papillomas have a distinctive look. Mucoceles, lingual thyroids, dermoid cysts all sort of look a little bit more distinctive, but more often not, it's just sort of asymmetric tonsillar tissue rather than a carcinoma when people notice something asymmetric on like a outside CT scan and then come to their ENT for like a scope exam, which will either show like a mass or it's just some asymmetric tonsillar tissue. So I would say it's frequently not cancer when it presents as like a tongue mass on a CT scan.
Cool, thank you.
All right, so imaging CT neck came next for this patient. And here we can see on the left this asymmetric base of tongue mass here, but also noted level 2B node. Okay. This was biopsied and came back as P16 positive squamous cell carcinoma. Patient underwent PET-CT demonstrating FDG avidity in the 2 known areas. So as far as treatment options for this patient, for a well-lateralized base of tongue mass with adenopathy, definitive chemoradiation, standard 70 gray and 33 fractions concurrently with cisplatin. There is an ongoing de-intensification trial, the HN005 trial, randomizing based on adverse risk factors of 60 gray and 50 gray. And then consideration of definitive chemoradiation alone to a smaller volume. Dr. Beadle, I was wondering if you would comment on this component.
I don't actually know what that means. I think that it's a small lesion, so he definitely could be a candidate for radiation alone. I think that typically we do kind of standard definitions for expansions and those kind of things. So I would feel comfortable doing kind of standard radiation alone for him, given the small size of the primary tumor and a single node.
Dr. Lukens?
I agree with that. Yeah, we would consider radiation alone for this patient. I think that's a good option, given the small size of the tumor and the node.
Okay, and in the interest of time, since this is a TORS discussion, option of TORS with neck dissection followed by postoperative radiation therapy. As Dr. Beadle stated, this is a smaller primary that is low lateralized to single node. As far as patient options, the patient elected to proceed towards surgery. This is the patient's pathology from TORS and neck dissection. So a 2.6 centimeter invasive squamous cell carcinoma with 2 out of 24 lymph nodes and level 2 positive for carcinoma. So as far as options following surgery for post-op radiation, the standard would be post-operative radiation therapy, 60 gray and 2 gray fractions to the primary site as well as the bilateral necks. As far as the other possibilities is the 2 trials that both Dr. Beadle and Dr. Lukens discussed, the PATHOS trial as well as ECOG 3111. stratifying based on pathologic risk assessment for recurrence. As far as indications for chemotherapy for a well-lateralized mass with no descriptions of ECE, no indications for chemotherapy. At this point, that's the end of our slide deck. I would be interested in comments from Dr. Beadle or Dr. Lupin on their thoughts.
I guess I would say this is a pretty favorable risk patient with only two nodes positive. Were there risk factors at the primary site, and what were the margins?
There were not margins for negative. There was no PNI and no LDS.
Okay, yeah. So I think I would feel comfortable treating this patient per the ECOG 3311 trial. I think it's actually in the spirit of that trial, just has really one intermediate risk indication for radiation. So we would expect the patient to do well. We have our own trial at Penn where we would spare the primary site and then further de-intensify the dose. Results haven't yet been published, so that's not the standard of care, but we would do that on trial.
This patient for us was actually enrolled on the Pathos study. And so he was randomized to 50 gray. So he'll get 50 gray to the primary site in the bilateral neck since it was invasive tongue cancer.
Thank you, everybody.
Great. I thank everyone for all the discussion today. And we're just at the end of our hour. We go to the next slide. We have all of our contact information here if you wanted to screenshot it quickly as the people who are running Rover and can get you in contact with the panelists if you like. If you would like to go to our future sessions or would like to view one of the prior ones, those are also posted on our website. And on to the next slide. We always have a big thank you for our panelists and also our Rover coordinator, Navjot, who basically runs our ship all the time. We will send out a post-panel survey if you can help us to improve all of our sessions in the future. And then finally, I believe we have a plug for our next one, which is going to be a panel on rectal cancer with short course versus long course radiation therapy with another case-based teaching session featuring faculty from around the country. Thank you so much, everyone, for coming today. And with that, we're done at 3 o'clock. Have a great weekend, everyone.
Thanks all.
Thanks for putting it together. Bye.